We have Dr. Nick Cohen, Dr. James Campbell, and Seth Balinsky, who will be presenting to us on 3 different approaches to care transition. So with that, I'm going to ask Dr. Cohen to start us off.
Thank you all for coming. My name is Nick Cohen. So I'm joined today with some super coaches. Super is supporting, understanding, promoting engagement, and resilience. There's 6 of them in the room. They're volunteers, and they're the heart of what I'm going to be describing today. My presentation objectives: by the completion of this presentation, audience members will compare models for facilitating health behavior change, learn about the E² program, which is evocation and empathy, and the super coach program, and consider collaborating with us. One of my mentors says, when everyone zigs, I zag, and so if you're looking for a traditional care transition discussion, this is not it, but it's I've certainly been working on care transitions for the past 2 years. So if you look at this recent report from America's health rankings, we're still ranked 40th in the nation for health. And we smoke more than the rest of the country. We're about as physically inactive. We're more obese than the rest of the country. We also have more primary care physicians than most of the country. So we're ranked 17th for primary care physicians, and we're ranked 45th for preventable hospitalization. So I'm a family doctor. I trained here at university hospitals, and it's been kind of a obvious thing that health behaviors, the things that people do when they're not in front of me for 15 minutes, are more important than that healthcare visit and determining their health, and that their exposure to me hasn't really moved the needle, either in preventing the behavior from happening or changing it once it does. So that was obvious to me, but I wasn't sure why. And I've been a fellow for 1 year and now I'm faculty. And I've been interested in doing quality improvement to answer that question since I began residency, so for 5 years. I have two, I didn't know I had 2 ideas. I thought I just had one. It was hypothesis A. Hypothesis B resulted when I came to a dead end with hypothesis A. So hypothesis A was the idea that people lacked the knowledge about what they needed to do, and they lacked the knowledge of what would happen if they kept doing what they're doing. And then they also lacked a good plan. I would give them the what, I would give them the why, and I would give them the how. And I thought the problem was the exposure time, that I had 15 minutes to do it. So I thought the solution would be just more time in front of them. So 2 years ago, I developed a coaching program. So I got all these volunteers to start teaching people about diabetes, because I could have, and we've trained 114 people, that would be more face time with you to talk about your condition. And I just had them lecturing the diabetics on the ABCs of diabetes, their A1C, blood pressure, and cholesterol. And then they broadened their intervention to everybody admitted to the family medicine service in the hospital. We were deployed on the hospital floor. What was obvious from observing these interactions was that the elephant in the room was disengagement. I mean, the people that were getting these lectures, and were in general the people admitted to the hospital, were not feeling too good about themselves or too hopeful for the future. So with the kind of the mentorship of Stefan Gravenstein, who's worked in the Coleman transition model in Rhode Island, I realized that maybe I was missing something for what these volunteers could offer. So we turned down the talking and we started to do listening, and to ask the patients, what is something that's important to you in the past couple of days, and what are you looking forward to when you go home? And the transformation was pretty powerful and pretty fast. Human beings who had lives and stories to tell and wanted to tell them, but these students, mostly pre-med undergraduates, also really wanted to hear them. They wanted to be able to connect with someone. They were going to healthcare and they realized this was a unique experience to have. And the coaches were not struggling with a deficit model to depart from. So I knew that something was good about this. I didn't know how it fell with my model of just telling people what to do, but I knew that there was ability to connect for these people who we hadn't trained in healthcare, and something different about that interaction than the rest of their interactions during their hospitalization. I also personally tested this hypothesis as a fellow. I was working with the 40 patients most frequently admitted to the hospital or the emergency room. So I took on primary care for them. These are very complicated patients. And my hypothesis was if I could get in front of them and cover all of their problems, I could reduce their utilization. I went to their homes, visited them every week for an hour at a time. And I didn't have a car until then. I bought one and I was going out to their house for these visits. And we really reduced reutilization. Towards the end of the fellowship, though, I had to think about transitioning them back to the care they were getting in our clinics. So I had to start to wonder how much of this is going to continue when I'm gone. I asked one gentleman about how he takes his insulin. He held up his Lispro and said, "This is my Lantus, and I take it once a day." And this is a guy I've been working with for a total of probably 30 hours in the past 30 weeks on his diabetes and his heart failure and tobacco use and alcohol use. And if anybody was getting health care, it was this guy. And I said, "Mr. T, can you just tell me exactly what you're doing? Because I'm not seeing that as your Lantus." And he said, "I can't tell you." And I said, "Why not?" And he said, "I can't read." This was another crack in the wall. My exposure time was the key missing ingredient model. So I started to think differently about what was missing in these interactions. And without actually giving you the punchline, I'm going to ask you to think about a behavior in your life, something you're doing now, or something you think you might do, some change that you could make that would make a big difference in you. So taking that idea, now I'm going to be your helper in this situation. I'm going to tell you this is something you really need to work on, okay? And if you don't work on it, then you're going to end up in the hospital. You might lose your legs. You might go blind. You might end up on dialysis. And the best way to do this is to keep a pill reminder system and a log. And you really need to get going. So let's go. So we do this a lot in audiences, and as they listen to somebody lecturing them, you can see the disengagement go over like a veil time. And then take the same thing. This is where we get to hypothesis B. So here, I'm going to ask you what it is that you'd like to change. And then I'm going to ask you what your best reasons are for making that change. And then I'm going to ask you how you think it would work in your life. And I'm going to give you a summary of what you've told me. And then I'm going to ask you what you're going to do next. So the people who were totally disengaged, angry, wanting to leave, actually giving up on any change at all from the first interview are now thinking, I feel empowered. I feel like I was listened to. I feel like somebody connected with me. And I feel like I could actually start working on my goal. So hypothesis B is really that the what, the why, and the how are already there, and probably better than anything we could come up with. And it's our role to create a relationship where we can bring that out. The training model we've developed is this empathy and evocation. And the training model, it's motivational interviewing, and there's a lot of evidence about how to train this well. So we're following all the best evidence. We want to design criterion-based objectives. So you don't sit in a class for 16 hours and then you get a certificate, but your completion is based on your performance. And then we wanted to pilot this program with layperson volunteers. So I knew that these volunteers had something. I knew that this connection I was seeing on the hospital floor meant something. I also knew that health behaviors were the challenge that we faced. So I wanted to now see if we could equip these volunteers who were great listeners and great at getting at values and what's important and priorities. I wanted to see if we could equip them in the language of helping people move through ambivalence towards positive behavior change. Then if these volunteers could start to help people change, in addition to listening, but start to bring out that change talk, evoke that change talk. We've got a workforce, a new workforce to deliver an intervention that's pressing and kind of not able to be tackled by the way we're currently delivering care. So the theory is empathy and evocation. So empathy is the ability for me to feel like you accept me and to actually feel like somebody else you feel like you're inhabiting the shoes of another person. Once I feel comfortable with you, I can talk about things that are sensitive, like my ambivalence about my behaviors. Maybe I really don't want to eat that donut, but I don't know if I really kind of don't know what I'll do without that pleasure. That's a very hard thing to admit to another person, and it takes a special kind of relationship to share ambivalence. That's the foundation. If you then have the skill to bridge and have me articulate the change side of my ambivalence, I can change. This is motivational interviewing. Technically, the way this happens is through complex reflections. It's essentially guessing at what the person is going to say instead of asking them a question about what they need. So I'm feeling really tired. You didn't sleep last night. The point is that if you give someone a guess at what they mean, it's an invitation to continue to elaborate instead of being brought outside of yourself and feeling like somebody is asking you to justify what you said. So what happens is it becomes like I'm thinking out loud. I don't have people questioning me and I have to give them information. It comes like one person's stream of consciousness. It's an amazing feeling. Complex reflections are extremely hard to do, and it's one of the core things that we teach. So this is an extremely fun program that we have, and the volunteers could speak to the things they do. You real play with a partner, meaning you really talk about a behavior change. All their conversations are audio recorded and then coded with an instrument that assesses fidelity to motivational interviewing. We then play the tape back, pause the tape, and we say, okay, how would you guys respond to this reflection, to that person's statement? So go in the room and then we continue the tape so you hear how it went. It's an enormously fun peer practice. And then journaling. This is a program that has just begun. So we started in March. We're using the mighty motivational interviewing treatment integrity coding instrument on 20-minute segments of each learner. These are expert guidelines for defining basic competency and proficiency in motivational interviewing. This is our dashboard of learners. And our results so far are pretty exciting. So of 17 students, none of them licensed healthcare professionals, all volunteers who have had 4 sessions. 5 of them have reached basic competency, 5 proficiencies. So we're talking about what a clinical trial would consider adequate for ability to deliver motivational interviewing. And the others are continuing to improve, as you can see by the averages. So my conclusions are that we have the potential for transforming conversations, and you can do any care transition intervention you like, because these coaches are sort of hematopoietic stem cells. You can place them into transition models that already exist. And a lot of these guys are pre-health, so they are a way of training the future healthcare force. And I'm hoping we're going to get AmeriCorps here. We are affiliating with CSU. I'd love to get this across to other systems too. So I want to stop now to give time to our other speakers. Thanks.